Good morning, everyone. Thank you for joining us today, bright and early. I'm Marina Roytman. I'm a hepatologist at UCSF Fresno, and I am super excited to kick this day of liver learning off. I see a lot of familiar faces. I see some of the new faces. Welcome to the new providers. I'm very excited to have you. And we are going to start the day about learning about steatotic liver disease. So major advances in MASH management. So moving on, this is actually a CME program, and it's jointly accredited by the Medical Education Resources, CLDF, GHAP, and the Global NASH Council. So this program has been very well vetted and is ready for you to absorb and get your 1 credit of CME. It has been supported by the Madrigal. We're very grateful to them for providing us this opportunity to learn. Let's see. This is the program designed for all of you to learn about metabolic dysfunction-associated steatohepatitis, as it's been renamed MASH. For those of you who may not know, we have new terminology. NAFLD has been renamed MASLD, and NASH has been renamed MASH. That's me. Again, thank you for coming to listen to me. And there is lots and lots of disclosures. Basically, the general message of this slide is it's been well vetted in terms of conflict of interest, and this should be a non-biased program for you to learn from. Okay, this is our planning committee. Very grateful for the MASH Alliance to put this together and allow us the opportunity to learn. And finally, to the educational objectives. So we will learn today about the epidemiological impact of MASLD. We will discuss the use of NIT, or non-invasive testing, in MASLD. We'll talk about the initial treatments, which include lifestyle modifications, as well as approved medications for cardiometabolic risk factors, specifically obesity and type 2 diabetes. We'll review the data on the currently approved medication for MASH, and we'll briefly touch base on the phase 3 clinical trials for MASH. So this is a packed agenda. Okay. Again, the accreditation statement, this is jointly accredited for 1 AMA PRA category 1 credit. And of course, you should only claim to what you've attended or participated in. In order to claim your credit, please write your name on the sign-in sheet and complete the pre-test. Complete the post-test and program evaluation at the end of the presentation to claim credit. Give it to our STAR staff up front, and virtual attendees will receive an email with a link to post-test evaluation to claim credit. So now that we're done with the preliminary slides, we'll jump into the meat of presentation. So MASLD and MASH is a current and growing crisis worldwide in the United States. And the reason that I say growing crisis is the overall prevalence of MASLD worldwide in the 90s was 17%. We are up to 30% globally now. In the United States, when we look at prevalence of MASLD, we are around 32%. In the Latin America, this is the highest prevalence of MASLD in the world, up to 44%. And this is certainly relevant to many of us practicing in California, and certainly very relevant to me practicing in the Central Valley with a very large Hispanic population. So that is something to keep in mind. So about 31% of patients in North America have MASLD. 68% of patients in North America with type 2 diabetes have MASLD. So pretty much close to 70% of patients with diabetes will have MASLD. Just let it sink in for you. Close to 70% of patients that we see every day have liver disease. Vast majority of them are probably undiagnosed. 5% of patients in North America have MASH. 5% doesn't seem like a lot, but 5% out of the entire North American population, that is a whole lot of patients. And this is the reason we're here to learn about it, because hepatologists by themselves will never be able to take care of all the patients with MASH alone, let alone the larger proportion of patients of MASLD. So it is my sincere hope that endocrinologists, primary care providers, will play a significant role in managing of patients with this growing pandemic. So why are we talking about MASLD? What is the importance of it? Well, really, MASLD, overall, just to start with, has a higher death rate. So all causes death from MASLD is significantly higher per 100,000 person years at 17 versus the general population of somewhere between 7 and 8. Oops, it went too far. So when we're talking about a general population with MASLD, the dogma is that it is the cardiovascular disease that kills patients with MASLD. And that is certainly very true when we're looking at overall MASLD population. We have to remember that there's still an increased risk of death from liver-related disease, as well as from the extrahepatic cancers. But overall, it's the cardiovascular disease that we have to focus in patients with MASLD. The story changes when we progress to patients with MASH-related cirrhosis or MASLD-related cirrhosis. So first of all, the all-cause mortality is massive. It is at 74 compared to somewhere between 7 and 8 for the general population per 1,000 patient years. So just that number is pretty staggering. The other thing that I want to point out, that at this point, liver-related mortality is at the forefront. So patients with cirrhosis, their primary cause of death is liver-related mortality. Certainly, we still need to pay attention to the cardiovascular risk, and it is significant. It's twice what it is in the general population, but we really have to focus on liver-related mortality in this patient population. So moving on, what ultimately are the predictors for mortality? And we're going to talk about cardiometabolic risk factors. And cardiometabolic risk factors is diabetes, first and foremost. This is the first question that I ask patients that I see with steatotic liver disease, is whether or not they have diabetes. What is their diabetes control? Certainly dyslipidemia, high blood pressure, central obesity are the other relevant metabolic risk factors. So if you have no metabolic risk factors, you're actually doing pretty good. I think your mortality is not significantly affected. However, if you even have one cardiometabolic risk factor, the mortality is increasing significantly. And if you have all 4 cardiometabolic risk factors, you can see that the mortality curve is significantly impacted. So again, paying attention to the presence of cardiometabolic risk factors is very, very important. So ultimately, at what point do we start worrying about the increase in mortality? I mean, certainly in the previous slides, I have shown you that once you've hit cirrhosis, your liver-related mortality and all-cause mortality skyrockets. But what I find interesting and concerning is liver-related mortality start rising at the stage 2 fibrosis. We are already at 2.5 times at the liver-related mortality at F2 fibrosis. And the vast majority of patients don't know they have F2 fibrosis. These are the patients that are entirely asymptomatic. And unless you actively test them for it, you will not know that these patients have early fibrosis and they're at a higher risk of liver-related mortality. When we look at all-cause mortality, so very similar. You're starting to see a significant increase, again, at stage 2. We had a 1.5% mortality, and at stage 4, you're 3.5% mortality. And at stage 4, with a liver-related specific mortality, you're at 11 times the mortality. So these are impressive numbers, and I hope that these numbers really make you think about testing and diagnosing patients with steatotic liver disease and evaluating the degree of their fibrosis. All right, moving on. So what about progression? So basically what this study looks at this is a study published in Hepatology in 2022 by Dr. Sanyal. And what this attempts to tell us is if your disease progresses, your risk of liver-related events increases significantly. If your liver disease regresses, your risk of liver-related events decreases significantly. So this is great to have. This is great to see that we can decrease the risk of liver-related events in these patients. So this is great to see, but as you can see in this study, it is hard to achieve. Lots of patients had disease progression, and very few patients had disease regression, at least in this particular study. So later on in the slides, we can focus on the strategies of disease regression, specifically fibrosis regression, because it is the fibrosis that kills. It is the fibrosis that is responsible for progression of liver disease to cirrhosis, progression to decompensated disease, and development of HCC. Okay, so how do we stage patients? How do we figure out where they are in terms of the degree of fibrosis? So we're going to start with something really simple. So non-invasive test, NIT stands for non-invasive testing, and FIB4 is probably something we're very familiar with, and it consists of a simple formula that includes age, AST, ALT, and platelet count. So many of you probably already have the FIB4 incorporated into your EMR. And if you don't have it incorporated, I strongly encourage you to incorporate that so you don't have to spend time calculating it, but it's already there for you. So the problem with FIB4 is that it's great to tell us that there's a low probability of advanced disease. If our FIB4 is less than 1.3, you're probably pretty great, and your patient has a low probability of having advanced disease. If your FIB4 is greater than 2.67, it's pretty great at ruling in the high probability of advanced liver disease. The problem is between 1.3 and 2.67, you are in the intermediate range. So this is a pretty good proportion of patients who fall into the intermediate range. So what are we going to do with those patients? So this is another slide that kind of highlights the limitations of FIB4. And I'll tell you about the limitations of FIB4 a little bit later in my other fatty liver disease lecture. Lots of learning about fatty liver disease today. But specifically, initially, the FIB4 was developed for fibrosis estimation in patients with HIV and hepatitis C. So it's a very different patient population from the get-go. So again, less than 1.3, we're pretty great. Greater than 0.267, we know where we are. But again, this is a large intermediate area that we are not sure where we are, which brings us to additional kind of higher level non-invasive testing. And vibration controlled transient elastography, VTCE, or FibroScan is probably my favorite test, my favorite non-invasive test, and it's becoming more and more accessible. The VTCE can tell you two things. It can tell you how much fibrosis or scarring your patient has and how much steatosis or fat does your patient have. So how does it do that? So if we think of a liver as a rubber ball, and a healthy liver is going to be nice and squishy, like a soft rubber ball. So if you send a shear wave, which is what the VTCE does, through this nice squishy rubber ball, the shear wave is going to travel relatively slowly through this nice and soft rubber ball. However, if the rubber ball is hard, like a cirrhotic liver is, the shear wave is going to travel a lot quicker, through this cirrhotic, rock hard rubber ball. So what we can do is we can correlate the speed of shear wave travel to the degree of fibrosis. So the faster the shear wave travels, the more fibrosis the liver has. So that's one thing that the FibroScan can do for us. The other thing that it can do for us, it can semi-quantitatively tell us how much fat or steatosis is in the liver. Well, how does it do that? So we're back to the rubber ball analogy. The nice, healthy liver is going to be homogeneous. So the shear wave is going to travel through a nice, soft, homogeneous liver, and it's not going to bump into anything. So it is not going to attenuate. However, if our liver or our rubber ball is full of fatty deposits, the shear wave is going to bump into this fatty deposits and it's going to get smaller or it's going to attenuate. The degree of attenuation again correlates to the degree of the steatosis. So this is a very handy test. It's non-invasive. It's becoming more and more available. It's inexpensive, and it gives us a whole lot of information. So I have to say this is my favorite non-invasive test. Okay. So this is again vibration-controlled transient elastography, and it talks a little bit about well, how good is this test? And when we look at the sensitivity and specificity, it's really good about differentiating between early fibrosis and advanced fibrosis. It may be not as good in the middle in distinguishing intermediate fibrosis. So is there anything we can do to further improve this test? So yes, there is. There is a relatively new test called FAST score. And FAST score combines liver stiffness measurement, which we've talked about, AST, and CAP, which is a measure of steatosis. And what the FAST score does, it tells you the risk of disease progression in a particular patient. So the higher the FAST score is, the more you should worry about the patient, the higher the probability that this patient disease will progress in the near future, and this is the patient that you should focus on. Moving on, the next NIT is something called ELF. ELF is a proprietary blood test that combines 3 separate markers of fibrosis. So this is a really good test. You can see on this graph that we have good differentiation between different stages of fibrosis. Probably the biggest downside of this test, at least in my patient population, which is underserved and frequently underinsured, is the coverage of this test. This test can run, several $100s for a patient, and I'm often reluctant to send the patient to the lab to get this test because they may be stuck with a high copay. But for those of you who practice in a different patient setting, that may be a great second NIT. Moving on to more sophisticated NIT, we have MRI PDFF and MRE. So MRE is basically MR-based elastography. So very similar concept to what we've discussed in terms of the VTCE, but with the MRE, you look at the entire liver. The problem with those tests is they're expensive, they are time-consuming to perform, and they're certainly not available in my setting unless the patients are enrolled in clinical trials. Certainly in larger institutions, those tests are more readily available, and I hope that as we get more sophisticated in management of patients with steatotic liver disease, those tests will become available to all of you as well. Okay, moving on. So now that we've learned about estimating the fibrosis, what is the relevance of knowing the fibrosis? So it turns out, again, to reemphasize, it is this fibrosis that kills. It is the fibrosis, again, to repeat myself, is associated with development of cirrhosis, decompensated cirrhosis, and development of HCC. And this is exactly what this graph tells us. So the higher the fibrosis level is, the higher the cumulative risk of complications, and liver-related events. This is your this is your highest score, FIB4, and this is associated with the highest incidence of liver-related events. What is really interesting up here is when we are starting with overall about 13% baseline events at FIB4. However, if we're able to decrease FIB4, our incidence of liver-related events is going to decrease. However, if your FIB4 increases, your liver-related events will correspondingly increase. So not only does it tell us that the FIB4 is predictive of liver-related events, the change in FIB4 itself is predictive of decrease or increase in liver-related events. So that is good to know. So again, this is a very similar slide, or again, further nailing in the point that the higher your liver stiffness measurement, the higher is the risk of complications and the lower your survival probability. So green line is the liver stiffness measurements of greater than 20 kPa. This is your patients with cirrhosis, and clearly you can see that their survival rate is significantly impacted. On the lower slide, there's a CAP score. This is the steatosis score. And the steatosis score of greater than 285 decibels per minute, again, is associated with decreased survival. As far as ELF, very similar. You can see that ELF with advanced fibrosis, F3 and F4, is again associated with more events, liver-related events, both in the F3 and F4 categories. The MRE is really interesting and more nuanced. So not only does MRE tell us that the higher your fibrosis level is, the more liver-related complications you will have, but it actually has an ability to predict with more nuances at what measure will you have decompensation, development of ascites, development of HE, and variceal bleeding, and at which point your patients will require other liver transplant or will unfortunately pass away from their liver disease. So a much more nuanced test for those of us who can get it. All right, so this is the challenging part of the talk. And basically, the gist of this talk, the gist of the next few slides is different societies have created different guidelines based on available non-invasive testing. And all of the societal guidelines tell us that biopsy at this day and age is not necessary when we're managing steatotic liver disease. I want to make sure that I specify if diagnosis is uncertain, if you are thinking there's a competing etiology, such as, for example, autoimmune hepatitis, by all means, go ahead and biopsy the patient to make sure you're targeting and treating the correct disease. But once the diagnosis has been firmly established and there's no concern for competing etiologies, the biopsy is not needed in vast majority of patients with steatotic liver disease. So basically, all the societies tells us that we should start with identifying patients at high risk for steatotic liver disease. So certainly there's going to be the patients with cardiometabolic risk factors. The more cardiometabolic risk factors they have, the higher is their chances of developing steatotic liver disease. Patients with persistently elevated liver enzymes, patients with abnormal liver imaging, all of those patients would be considered for at high risk for steatotic liver disease. And again, remembering that close to 70% of patients with diabetes will have steatotic liver disease. You know, if anything, this is the patient population that we focus on. So once we've identified the patients to be concerned, we're going to calculate their FIB4. If they are falling into the intermediate category, we will look at other additional non-invasive testing, such as vibration controls, transient elastography, MR-based testing, or potentially ELF. And depending on where those patients are, those patients can be funneled into remaining with you in primary care, or being funneled into the hepatology care for more aggressive management of liver-related disease, aggressive endocrinology care for management of cardiometabolic risk factors. I'm not going to go over each algorithm. Each algorithm basically tells us that same thing. The biopsy is not necessary. We should rely on non-invasive testing sequentially, and we should funnel the patients either to remain in the primary care or towards hepatology and more aggressive management of cardiometabolic risk factors. So this is the endocrinology guidelines. This is the ASLD practice guidelines. And this is EASL guidelines. All of these are available online. I use the ASLD guidelines. I find that the most user-friendly and applicable to our patient population. So once we've decided, once we've performed initial testing as well as advanced testing, this is a nice table that tells us when we should start worrying about the patients. This is detection of advanced fibrosis, and I'm not going to make you memorize all those numbers, except for the VCTE, which I'm partial to. This is a 12 kPa number. This is when you need to start worrying that my patient has advanced fibrosis. Same for cirrhosis. This is, again, VCTE greater than 20 kPa. This is when my patient has cirrhosis and I should really worry about them. So once we've decided that we've evaluated the patient, we know where they are in terms of their fibrosis, what do we do with them? So first of all, we are going to start with lifestyle modification. So certainly, and basically the lifestyle modifications will be tailored to where your patients are. Are they at low risk, intermediate risk, or high risk? Certainly, general lifestyle modifications is increase in cardiovascular activity, decrease in sedentary life, and a lot of the times this is easier said than done. And I'm going to call out my fellow, Dr. Chadalawada, who is great at talking about lifestyle modifications with patients. She's really great about meeting patients where they are. If the patient is really not doing anything, how about adding just 5 minutes of walking? If the patient is walking twice a week, how about adding the third day? So really meeting the patient where they are and working from there. So this is really awesome. Dietary modifications. The more we talk to patients, the more I talk to patients, the more I realize patients don't really know what healthy eating is. I was talking to a group of highly educated women last weekend, and we've talked about, what is healthy eating? What is good for your liver? And I've talked about avoiding highly processed food, avoiding sodas, avoiding, again, packaged processed foods. And about half an hour after my conversation, one of them had ordered a diet soda. And she was looking at the diet soda and saying, wait, this is not healthy. I did not realize that until our conversation. And this is, again, a group of highly educated people that I know. So really spending time and educating your patients on what are processed food, what is it to avoid. Diet soda is not healthier than regular soda. All of those things are really critical, and we are overestimating what our patients know. Exercise, moving down, we're certainly improving cardiometabolic health. We are supporting weight loss. We mitigate sarcopenia, osteopenia. Aerobic exercise, generally 30 to 60 minutes, 3 to 5 times a week, and resistance training, especially for patients with advanced liver disease and sarcopenia. Resistance training is really important. Weight loss tools, again, targeting to where your patients are. At a low risk, we're going to look at behavioral modification, counseling, in person. Remote programs have really blossomed. So this is something that we can take advantage of. As the risk increases, greater intensity of weight loss to reverse fibrosis and steatosis should be targeted. And certainly at the more advanced risk, we really should engage patients in specialized obesity management with structured programs, anti-obesity medication, bariatric surgery should be considered. Medication therapy, again, in the earlier side of it, we have a lot more different choices of medications. If you are comfortable prescribing anti-obesity medication, that's wonderful. I think as the time progresses, more and more of us, including the hepatologists, will need to become comfortable with management of obesity. As we progress towards more higher risk, probably the GLP agonist will be more useful in management of obesity and management of diabetes. And again, bariatric surgery, again, with stratifying patients on low, intermediate, and high risk, with the caution as patients progress towards cirrhosis and certainly towards decompensated cirrhosis, any surgery, specifically bariatric surgery, will become more risky and should be taken with caution. This is European EASL guidelines, or European Association for Study of Liver Disease. And again, it's just a different format of emphasizing what we've talked on the previous slide. So certainly the best thing to do is prevention of MASLD, prevention of obesity, healthy diet, regular physical activity, and avoiding of smoking and alcohol. Now, weight loss goals. There is quite a bit of different numbers that are being thrown around in terms of weight management. When I talk about weight management to my patients, I actually focus on 10% total body weight loss, not 5%, not 7%, but 10% for the vast majority of the patients. The reason I focus on 10% is the only number that is associated with decrease in fibrosis. Certainly, we can decrease steatosis with lower weight loss, but again, it is the fibrosis that kills, and we want to reverse fibrosis. Therefore, we should aim for 10% total body weight loss. 10% is not that much. If you're seeing a patient who is 200 pounds, all we're asking them to lose is 20 pounds. We're not asking for 40 or 50 or 60 pounds. 20% is manageable for a lot of our patients, and this should be the target goal, I believe. The only exception here is the patients with MASLD who are of normal weight. Those patients probably do not need to lose 10% of total body weight loss, and the target for them would be 3 to 5%. We see MASLD with normal weight a lot of the times in our Asian population, and this has to do with the different build. Asian patients tend to have a lot more visceral obesity. So even though they may be not obese by the Caucasian BMI standards, because of the visceral obesity, they're at a higher risk of developing MASLD and progression of MASLD. Let's see, dietary recommendations. So Mediterranean diet probably has the highest level of evidence for managing of patients with MASLD. So Mediterranean diet is great. Probably most of us in this audience know what Mediterranean diet is. However, a lot of our patients really don't know what Mediterranean diet is. And one of my star medical students realized that our Indian population, we have a large Indian population in Fresno where I practice, has no exposure to the Mediterranean diet. So how do you do Mediterranean diet in the constraints of the Indian diet? And she actually came up with a pamphlet of how to do Mediterranean diet Indian style. So I thought that was spectacular. And this is something that we're going to use in our clinical practice. And we're going to look at other diets. We also have large Asian population, specifically Hmong population. So can we adapt the Mediterranean diet to this patient population? I certainly hope that we can. And I hope that we can share those type of materials with all of you if you're interested in this population that you're caring for. Physical activity, again, a variety of recommendations for physical activity. Here we have 150 minutes a week of moderate activity or 75 minutes of vigorous activity. And again, meeting the patients where they're at is what it's all about. A lot of the patients are interested in what we as providers are doing to stay well from the standpoint of fatty liver disease or steatotic liver disease. I freely share with my patients that my way of staying liver healthy is hot yoga. I've converted a number of patients into the hot yoga addicts, and they are doing great. Let's see. Implementation. This is really tricky. Multidisciplinary care is key. So it is amazing and wonderful if you can employ multidisciplinary care. If you have a dietitian, if you have an exercise specialist, if you have an endocrinologist, if you have an exercise physiologist, this is wonderful. But a lot of us, I'm guessing, practice in underserved areas. Certainly, I practice in underserved area. And a lot of the times, my fellows and I are that multidisciplinary team. So we do need to be able to counsel patients on their dietary habits. We do need to counsel the patients on exercise. So just because you do not have access to that fancy multidisciplinary team, it does not mean that you cannot provide your patients with quality care. So I do encourage you all to do that. In terms of goals, our long-term goals is improvement in quality of life and survival, certainly transplant-free survival, management of cardiometabolic risk factors, prevention of cirrhosis, HCC, and cardiovascular disease complications. So what is the evidence in the types of diet that we're recommending to patients? So as I already mentioned, the Mediterranean diet has the highest level of evidence. Low-fat diet has a decent level of evidence. Lower level of evidence is low-carb, time-restricting diet, and my least favorite diet is ketogenic diet. Ketogenic diet is not heart healthy, and this is one of the diets I would definitely avoid recommending to patients. I know patients can lose weight on it, but at the expense of their cardiometabolic risk factors. All diets should minimize ultra-processed foods, sugary foods, drinks, and saturated fat. So, impacts of Mediterranean diet. So there has been a number of studies that have been looked at that have improved liver stiffness, insulin resistance, and FLI of fatty liver index. So we do know with a pretty good degree of certainty that Mediterranean diet is good for steatotic liver disease. What about intermittent fasting? This is the slide that I was looking for. So there's a number of ways that we can engage in intermittent fasting. Alternate day fasting, 5-2 diet, time restricting eating. And we have decent evidence that it improves liver stiffness, it improves liver steatosis. It does achieve about 3 to 8% of total body weight loss in about 8 to 12 weeks. So these are all great. But the problem is these are really, really hard to stick to for the rest of your life. It's very hard to not eat every other day. It's very hard to eat within time restricted parameters. So the discussion that I have with patients about time-restricted diets or intermittent fasting, if you can commit to lifelong diet and you can avoid the yo-yo effect of coming on and off the diet, gaining weight and losing weight, by all means, this may be a diet for you. But if this is not something you can commit for lifelong, this is probably not something that we want to focus on. Exercise. Exercise is great for people. It's great for reducing liver fat, cardiovascular health. It's great for body composition, cardiorespiratory symptoms. It improves your mood. It improves your quality of life. And what is really interesting, what I see in my patients who begin an exercise program, is their liver tests improve even before there's a significant weight loss. So I think there's something magical about exercise. When the patients engage in exercise, their liver health improves even before they lose weight. So whatever intervention that we talk to patients, exercise has to be an integral part of it. What about weight loss beyond lifestyle modifications? So there's a number of medications that are on the column up here, including orlistat, agonists are co-agonists. So this is probably the least invasive ways of losing weight. The most invasive is surgical, gastric bypass, sleeve gastrectomy. And in the middle, we have kind of moderately invasive interventions such as gastric balloon, sleeve gastroplasty, overstitch, which is an endoscopic intervention, and duodenal mucosal resurfacing, which basically causes malabsorption of calories and helps you lose weight that way. They all do help with weight loss, but we do have to recognize that none of these are FDA approved specifically for treatment of MASH. What about optimizing cardiometabolic risk factors? So for type 2 diabetes, we have lots of options. We have GLP-1 receptor agonist. We have SGLT2 inhibitors. We have metformin, insulin in case of patients with decompensated disease. Statins probably should be put in water. It's so good for many different things. Great for management of dyslipidemia in the setting of MASH. And for obesity, again, we're back to the GLP-1 receptor agonist as well as bariatric interventions. 2023 ASLD guidance, which is probably rapidly aging, so I'm not going to spend a whole lot on this slide, except to point out that metformin, urso, statins, and my favorite one, silymarin, are not well studied in NASH and should not be used in treatment for NASH, as they do not offer meaningful histological benefit. So this is what we should not recommend to patients. Moving on. So second step in MASH management is liver-targeted MASH treatments. So that brings us to resmetirom, which is the first FDA-approved drug for MASH. It's an oral partial agonist of thyroid hormone receptor beta, or THR beta, and that it has been approved in March of 2024 for treatment of adults with MASH with moderate to advanced fibrosis. This is F2 and F3. In conjunction with diet and exercise. And I want to emphasize that resmetirom is not a magic pill. It is not instead of diet and exercise, but it's in addition to. So how does that work? I'll tell you how I talk about it with my patients. Basically, I tell the patients, listen, you know that in order to have a healthy metabolism, we do need to have a healthy thyroid, correct? Most patients know that. So what resmetirom does, it basically treats local hypothyroidism in the liver. treating local hypothyroidism in the liver, decreases intrahepatic triglycerides, it decreases fat load in the liver, it decreases inflammation in the liver, decreasing inflammation in the liver, decreases fibrosis in the liver. So a more fancy way of saying that, it stimulates lipophagy, it stimulates mitochondrial biogenesis, it inhibits lipogenesis, and interferes with fibrinogenesis by inhibiting TGF-beta signaling. So this is the mechanism of action. So what MAESTRO-NASH is a phase 3 randomized controlled trial of resmetirom, which brought us this approval. It included about 900 patients. About a third were in the placebo arm, about a third were in the 80 milligram arm, and about a third were in a 100 milligram arm. And the endpoints, which is the holy grail of MASH management, and this is what FDA requires, is MASH resolution without worsening of fibrosis and improvement in fibrosis without worsening of MASH. And there has been many drugs that have attempted to achieve these dual endpoints, and so far only resmetirom has been able to achieve those endpoints. So this is the data. As far as MASH resolution with no worsening of fibrosis, we were able to achieve this in about 25 to 29% of patients. So this is pretty good. This is fibrosis improvement without worsening of steatosis. Again, we're somewhere at about 0.25% of patients. And you can see the percentage change in LDL by week 24, which is also nice to know. So you may want to ask me, we're only seeing a roughly 25% reduction. Why is that? Why are we not seeing a more robust reduction? So my answer to this is it took patients years and often decades to get to the degree of fibrosis of F2 or F3. This data is based on 52 weeks of treatment. So my hope is, as the treatment progresses, we will see more robust treatment effects beyond what we're seeing at 52 weeks, and time will tell. In terms of side effects, those of you who have used resmetirom know that diarrhea and nausea are probably the most frequently encountered side effects. So we do need to counsel the patients on the possibility of them developing side effects. Not everybody develops them. Those who do develop them early in the disease process, in the treatment process. And we do need to counsel the patients that if they stick through the next few weeks of these side effects, a lot of the times the side effects taper and they're able to tolerate the treatment very well. Couple other things that I want to mention with regards to side effects. We always worry about hepatotoxicity with any drug, and certainly with a liver-specific drug. There was one patient in MAESTRO study who developed significant hepatotoxicity. And probably this patient had underlying autoimmune disease, which flared in the setting of treatment with resmetirom, but it was very unlikely a direct effect of resmetirom. So the patient was treated and has done well. The other thing is there's a higher incidence of biliary disease that was noted in the treatment arms of the MAESTRO-NASH trial. We do know that patients with MASH and cardiometabolic risk factors are intrinsically at a higher risk for biliary disease, but there was a difference in the treatment arm. So again, paying attention to the biliary disease and certainly holding treatment if such disease develops. Dosing is very easy. If the patient is less than 100 milligrams or 220 pounds, they are going to get 80 milligrams tablets. If they are greater than 100 kilograms, they're going to get 100 milligram tablet. Certainly, we want to make sure that we rule out alternative causes of liver disease, such as autoimmune hepatitis. I do want to emphasize that resmetirom is approved for patients with F2 and F3 fibrosis, and it is not approved for patients with cirrhosis. And certainly we want to look at drug-drug interactions, specifically at the need for potential dose reduction in statins. So, fortunately, AASLD guidelines came up with a guidance for initiation and management of patients on resmetirom. And these are the numbers. So, initiation of resmetirom is based on presence of F2 or F3 fibrosis. And we can use vibration control chains and elastography. The numbers here is anywhere from 8 to 15 kilopascals. We can use the MRE if it's available, or we can rely on liver histology. Those of you who are paying close attention to this slide are probably wondering what in the world is NILDA. So NILDA is a different term for NIT. So NIT is non-invasive testing. And NILDA is a term that AASLD is proposing, is non-invasive liver disease assessment. So we will see if NIT or NILDA wins out in terms of the terminology, but that's what that means. It certainly should not be used in patients with cirrhosis, other concomitant liver disease, excess alcohol use, or active thyroid disease. I have to emphasize active and uncontrolled thyroid disease because MASTER-NASH trial included patients with well-controlled thyroid disease. About 13% of patients had thyroid disease, so this is not an exclusion, but the disease has to be well-controlled and well-managed. And it may be used outside of this criteria. Probably this is best left to the decision of the subspecialist. So how do we monitor the patient on resmetirom? So before we start the patients, we want to look at the safety assessment. We want to look at the liver test, thyroid test, lipid profile, and we certainly need to have some form of non-invasive testing. Probably FibroScan is going to be most accessible for most of us, and MRI PDFF may be accessible for some of us. At 3 months, all we need to do is look at the liver enzymes. At 6 months, we want to look at the liver enzymes, thyroid function, and lipid profile. At 12 months, we're going to repeat our safety assessment. And at 12 months, we want to repeat the efficacy assessment. And again, you remember that patients took a long time to develop the fibrosis, and it's going to take a long time to see improvement in fibrosis. So repeating the efficacy assessment prior to 12 months is probably not helpful. So I would definitely wait for full 12 months of treatment to repeat either VCTE or MR-based management. So assessment. So anyways, when do we stop treatment? Well, obviously, if our non-invasive testing or our NILDAs are worsening, if there's a consistent increase in ALT, this is considered to be no response, and we're going to stop resmetirom. If we have improvement, and AASLD had set very specific guidelines for what is considered improvement, this is improvement in liver stiffness measurement by 25%. Or MRE by 20% from baseline, or normalization of significant improvement in ALT. This is considered to be beneficial response, and we're going to continue treatment. And benefit uncertain, you have some reduction, but less than pre-specified numbers. There's no significant improvement in ALTs, and there's less than 30% reduction in MR-PDFF. Benefit is uncertain, and you may want to reevaluate your strategy. So a little bit about what's on the horizon. So the exciting things, there's lots and lots of things are on the horizon. We're going to have more THR beta agonist. This is exciting. This is in its stage 2 development. GLP-1 agonist and co-agonist. This is definitely happening. Semaglutide is probably the furthest one, along with the combo drug in the phase 3. We have PPAR agonists that are actively catching up. So it is a very exciting time to be in fatty liver disease. We do have to realize that even though the data in phase 2 trial is promising, it's really only phase 3 data of completed trials that is clinically relevant. So where are we at this point? So where are we in terms of the clinical trial management, and how do we think of it? So we are, liver disease is a spectrum, anywhere from the healthy liver to steatotic liver to fibrosis to cirrhosis to liver cancer. And the way we think about it is the earlier you are in the disease, safety is so much more important because we do not want to cause harm to patients who are relatively healthy. As the patient's liver disease progresses, certainly our risk tolerance will increase because these patients have real disease. So we may be able to tolerate more risk compared to risk tolerance in patients with earlier disease. So probably the future of steatotic liver disease is combination therapy. We're going to need to look at combination therapy of managing metabolic effects of liver disease combined with antifibrotic liver disease and antifibrotic effects. And this has been true in HIV. This has been true in chronic hepatitis C. And this is probably the future of steatotic liver disease as well. And again, lots of promises in phase 2 trials, but we do need to see how it all pans out in phase 3 trials. Last but not least, MASH and its complications are growing. This is a complex disease, and it will require multidisciplinary management. And certainly the hepatologists by themselves will never been able to manage the tsunami of steatotic liver disease that is engulfing us. So really my hope and my plea to all of you, please learn how to diagnose and manage steatotic liver disease. It's getting more accessible, it's getting simpler, and there's more and more educational materials out there. And please help us and please help your patients manage this complex disease. And as far as the hepatologist, we're more than happy to be a resource for you and to certainly help you manage patients with more advanced liver disease. Thank you.
Can this medication be used on people who underwent bariatric surgery, lost the weight, but they still have significant fibrosis?
So this is really a great question. And I would say that this is the population where I would lean heavily on the use of the resmetirom, because these are the patients that you've pretty much taken care of cardiometabolic risk factors, right? A lot of the patients who underwent bariatric surgery have lost weight. Their cardiometabolic profile is healthier. A lot of them no longer have diabetes. Their lipid profile has improved, but they still have advanced fibrosis. So I would say really leaning on resmetirom for fibrosis reversal would be the right patient population to address that in. Anybody else?
Yes. How often are you evaluating with the FID for patients in which you are addressing the?
So FIB4 is is an initial screening test. I think my practice is really to follow the patients with vibration controlled transient elastography or FibroScan, because I feel that this gives you a more nuanced way of understanding where the patients are in terms of the fibrosis and steatosis, rather than just like kind of a snapshot of FIB4. So my preference is to follow the patients with VCTE rather than the FibroScan. In terms of how often to follow the patients, I think if your patients are really loaded with cardiometabolic risk factors, and we're not making much progress in management of those cardiometabolic risk factors, I would follow them yearly with VCTE. If your patients are making progress or they did not have a lot of cardiometabolic risk factors to begin with, specifically no diabetes, I would say following them every 2 to 3 years is sufficient. Right. Yes, please. Managing what? Lean MASH patients. So that's a really, again, a great question. And this can be a challenging population. So I think definitely leaning, in my approach, is leaning more heavily on exercise. And I found that these patients, even though they do not lose significant amount of weight, but engaging in cardiovascular exercise really makes a profound difference in their visceral fat, in their body composition, and therefore in their cardiometabolic risk factors and MASH. So exercise is key. And again, potentially resmetirom in patients with more advanced fibrosis would be of benefit for this patient population.